Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
When you're preparing for a complex operation, there's just this baseline expectation of, well, absolute geographical certainty.
Yeah. You want to know exactly what's there.
Exactly. I mean, you look at an MRI or a high-res CT scan, and you see the mass, or you see the stricture. You get the exact millimeter coordinates, and it's just there. It's static. It's comforting. You can plan your entire approach around anatomy that just politely holds still for you.
Which is great because we rely entirely on that spatial predictability. I mean, as a surgeon, you want to know exactly where the vital structures are before you even think about making an incision.
Right. But then, and that's why we're doing this deep dive today, then you step into the world of the esophagus.
Oh, yeah. That's a whole different ballgame.
It really is. You start dealing with swallowing dynamics, motility, peristaltic waves, and suddenly that beautiful static snapshot, it just isn't enough. We're looking at a diagnostic landscape that is literally a moving target.
Because it's a muscular tube in constant motion. And, that dynamic reality is exactly why we're pulling from today's stack of sources.
Yeah, absolutely.
We're diving into the ACR appropriateness criteria, the latest UEG and ESNM guidance, plus some really contemporary surgical literature, because we want to unpack the modern clinical utility of dynamic luminal imaging, specifically the esophagram.
Which is huge for the surgeons and doctors tuning in today.
Exactly. I mean, endoscopy usually gets all the spotlight, right?
Mm-hmm.
But today we are looking at exactly when and why dynamic fluoroscopic imaging remains just an indispensable tool for your surgical and gastroenterological planning.
Well said. But before we jump in, a quick reminder that this content is strictly for reference only. Always ensure you are following your local guidelines in your daily clinical practice.
Absolutely essential to keep in mind.
Okay, so let's start with this major point of friction that I feel like happens almost every day on the wards.
The classic ordering mix-up.
Yes. You put in an order for a swallow study. Right.
Yeah.
Because you have a patient with retrosternal dysphagia and you suspect, say, a mid-esophageal stricture.
Right. A structural blockage.
Right. So the report comes back, and it's this beautifully detailed, multi-page breakdown of the patient's oral prep phase, their pharyngeal mechanics, aspiration risk. But it tells you absolutely zero about the esophageal body.
Yeah. You ordered a swallow study, but radiology protocoled a modified barium swallow VFSS.
It is maddening. I mean, the terminology gets conflated constantly.
It does, yeah. But structurally and clinically, the VFSS and a standard esophagram are answering two entirely different mechanical questions.
Totally different.
I mean, the modified swallow is an oropharyngeal test. You're usually standing there side by side with a speech and language therapist, right? You're administering different consistencies of food to see if the airway is protected. It fundamentally just stops at the upper esophageal sphincter.
Right. Whereas the standard esophagram evaluates the entire transit.
Yeah.
From the pharynx down through the esophagogastric junction and right into the proximal stomach.
Exactly. And for the surgeons and proceduralists listening, you're ordering this to evaluate the tube under load.
Under load, yeah.
And that means you have to be highly strategic about whether you're ordering a single or double contrast study. We don't need to retread the basic composition of barium here, but the clinical decision-making changes your entire surgical roadmap.
Yeah, so like if you have a patient presenting with profound solid food dysphagia and you suspect a gross structural abnormality, maybe a tight malignant stricture or massive tortuous achalasia, you want the single contrast study.
You do.
Because the goal there is just sheer luminal distension. You want a heavy column of liquid barium to fill the space entirely so you can see the stark silhouette of the narrowing.
But, and this is where people trip up, if the presentation points toward mucosal disease, early erosive esophagitis, superficial ulcerations, or tiny early-stage carcinomas.
A thick column of barium is just going to hide all of that.
Exactly. It totally obscures the subtle pathology. You need the double contrast study. By introducing effervescent granules to, distend the esophagus with gas, and then using a higher density barium to thinly coat the lining, you throw the mucosal relief into sharp, high-definition contrast.
It's like painting the walls so you can see every crack.
Right. You catch those superficial lesions that might be completely masked by the folds of a collapsed esophagus on a single contrast scan.
I always visualize it this way. If an endoscopy is like looking at a high-resolution static photograph of a highway to check the pavement for specific potholes.
Oh, I like that analogy.
Yeah. Then the esophagram is the live traffic camera. I mean, you don't just want to look at the asphalt. You need to see the flow, the bottlenecks, and how the traffic behaves when the whole system is stressed.
That's spot on. The endoscopy tells you what the tissue is, but the esophagram tells you how the tube functions mechanically.
Right.
Which actually brings up this interesting paradox in how we map unexplained dysphagia.
Oh, the standard clinical pathway.
Yeah. Endoscopy is almost universally the first-line investigation, right? Because of the direct visualization and the ability to grab a tissue biopsy.
Which makes sense.
It does. Yet, time and time again, you have these patients presenting with classic intermittent solid food dysphagia. They undergo a completely normal EGD, and they're told, hey, nothing is structurally wrong.
Because the endoscope actually defeats its own purpose in certain edge cases.
Exactly.
I mean, think about the Schottky ring. Structurally, we're talking about this thin, concentric mucosal web, typically located at the squamocolumnar junction.
Right.
And it often occurs as a protective response to chronic acid exposure, just above a hiatal hernia.
Right. It's a very subtle, fragile anatomical narrowing.
Super subtle. So the endoscopist goes in, and to see anything, they have to insufflate, right? They're pumping air, artificially distending the lower esophageal sphincter and the distal esophagus. And the sheer pressure of the scope and the insufflation physically stretches the Schottky ring wide open. Or the scope just blindly slides right past it. The static camera misses the subtle structural flaw because the act of looking alters the anatomy.
But on a barium swallow, the patient swallows a solid challenge, right? Like a barium tablet or a coated marshmallow.
Yeah, the marshmallow test.
You watch it travel down under natural physiological conditions, and suddenly, boom, it impacts right at that distal ring. The traffic camera catches the exact bottleneck that the static photo missed entirely.
Okay, but let me pause and play devil's advocate on this clinical pathway for a second.
Sure, go for it.
If I have a patient with a suspected complex, dense stricture, maybe they have a history of severe caustic ingestion or, radiation therapy, and I need to know exactly what I'm dealing with so I can plan a dilation or a stent.
Right.
Endoscopy gives me direct, illuminated vision and histology. Why would I delay the therapeutic intervention to send them down to fluoroscopy for a map?
Because going in blind with an endoscope in those specific structural scenarios carries an unacceptably high risk of perforation.
Ah, right. You're pushing against a wall.
Exactly. You are dealing with dense fibrotic scar tissue that drastically alters the normal luminal axis. Barium maps that altered anatomy first. It gives you the precise length of the strictured segment, the luminal diameter, and, crucially, information about the distensibility of the walls.
So you know what tools you need before you even go in.
Exactly. You need to know if you are dealing with a short, web-like stricture or a long, tortuous, rigid segment before you select your dilation balloon or your stent size.
And frankly, the risk of perforation is even higher when we talk about diverticulum.
Oh, absolutely.
Take a Zinker's diverticulum. The pathophysiology there is a mucosal herniation through Killian's triangle, which is this natural area of muscular weakness between the inferior pharyngeal constrictor and the cricopharyngis muscle.
Yep, the classic weak spot.
Over time, those high pharyngeal pressures force a pouch to form posteriorly.
And if you push a scope down an esophagus with a large Zinker's, the scope has this natural tendency to preferentially intubate that blind pouch instead of the true esophageal lumen.
Which is terrifying.
It is, because if you apply forward pressure without realizing you're in the diverticulum, you will push right through that thin mucosal wall directly into the mediastinum.
And that's a disaster. So the esophagram provides the vital spatial awareness. It defines the size of the diverticular neck, its orientation, and exactly where the true lumen actually continues.
Exactly. It neutralizes that blind spot before the endoscope is even unpacked.
Okay, so we use the esophagram to define physical blockages and protect our operative approach. But let's shift gears from structural walls to mechanical failures.
Motility disorders.
Right. This is where the sheer physics of the esophagus takes over, and the live traffic camera becomes the entire basis for your surgical decision-making.
Achalasia is the classic example here. I mean, the underlying failure is the degeneration of the inhibitory neurons in the myenteric plexus, right? The lower esophageal sphincter fails to relax during a swallow, and the esophageal body loses its organized peristaltic waves.
It just becomes this dilated atonic reservoir.
Right. And everyone knows the classic bird's beak tapering at the GE junction on a standard swallow.
Sure, from med school.
But diagnosing achalasia isn't really the primary challenge anymore. High-resolution manometry does that brilliantly. The real challenge is quantifying the mechanical failure, which is where the timed barium swallow comes into play.
The timed swallow.
With a timed swallow, you administer a standardized volume of high-density barium, typically around 200 milliliters, and you capture upright radiographs at 1, 2, and 5 minutes.
So you're actually measuring the height and width of the retained barium column. You're quantifying the emptying capacity.
Precisely.
But why is that so crucial when we already have manometry data? I mean, don't we already know it's not emptying?
Because manometry can sometimes give you garbage data in end-stage cases.
Oh, interesting.
Yeah. If you have a patient with a massive sigmoid megaesophagus the tube is wildly dilated and tortuous, the manometry catheter can literally coil back on itself inside the lumen.
Wow.
It fails to accurately cross the lower esophageal sphincter, and the pressure readings are completely uninterpretable. The timed barium swallow ignores the pressure data and gives you the objective, indisputable volume of what is actually emptying into the stomach.
And that objective volume is the ultimate benchmark for monitoring treatment response, isn't it?
Exactly. Whether you opt for a pneumatic dilation, a laparoscopic Heller myotomy, or, a POEM procedure.
And oral endoscopic myotomy.
Right. You need to prove that you actually relieved the mechanical resistance. A postoperative timed barium swallow gives you a quantifiable delta. You can objectively show, look, the 5-minute column height decreased from 10 centimeters down to 2 centimeters.
It provides the architectural proof of success.
It really does.
But what about the opposite end of the motility spectrum? Not things failing to open, but things squeezing with chaotic, overwhelming force.
Hypercontractile disorders.
Yeah, like diffuse esophageal spasm.
So the pathophysiology there is a disruption of the normal sequential timing of the peristaltic wave. Instead of a coordinated top-down clearing contraction, multiple segments of the esophageal body fire simultaneously and violently.
And on an esophagram, this creates that famous corkscrew or rosary bead appearance.
Exactly. The barium gets trapped between these massive, uncoordinated tertiary contractions. It literally looks like a spiral staircase.
And seeing that completely alters your surgical approach.
Okay.
If a patient presents with non-cardiac chest pain and dysphagia, and you discover a corkscrew esophagus, you know immediately that a standard lower sphincter intervention won't solve the problem.
Right.
The entire esophageal body is fundamentally out of sync.
And the UEG and ESNM guidelines are very explicit about this relationship. High-resolution manometry is definitively the gold standard for classifying the specific subtype of a motility disorder. But the esophagram is vital for clarifying the physiological context. It answers the fundamental question. Is this poor emptying due to primary dysmotility, or is the dysmotility actually secondary to a mechanical outflow obstruction?
Which perfectly sets up the most critical preoperative consideration for anyone performing anti-reflux surgery. Let's talk about hiatal hernias and Nissen fundoplications.
This is crucial.
This is where the mechanical physics of the esophagus directly collides with surgical intervention.
Definitely. When you perform a fundoplication, you are taking the fundus of the stomach and wrapping it around the distal esophagus, right? To recreate the high-pressure zone of the lower esophageal sphincter.
You're building a mechanical dam to stop acid reflux.
Exactly. But if you build a dam, you better make sure the river has enough current to push water over it.
Wow, that's a great way to put it.
A sliding hiatal hernia fundamentally alters the pressure gradient between the thorax and the abdomen. Over time, that structural disruption can lead to secondary esophageal dysmotility. The peristaltic waves become weak and ineffective.
So if you take a patient with weak peristaltic reserve and you perform a tight 360-degree Nissen wrap.
You've just created an insurmountable functional obstruction.
Right, because the esophagus simply does not have the muscular power to force a food bolus through that new high-pressure zone.
Exactly. You cure their reflux, but you leave them with crippling, potentially irreversible postoperative dysphagia.
And that is exactly why so many surgical series mandate a routine barium esophagram before committing to a fundoplication.
Absolutely mandatory.
You need to document the exact anatomy of the hernia, differentiating a simple sliding hernia from a complex paraesophageal hernia where a significant portion of the stomach is actually migrated in the chest.
Right.
But more importantly, you need to prove the peristaltic reserve. You watch the barium clear. If the esophageal body is sluggish and atonic, you drastically alter your surgical plan.
Right. You might pivot from a full Nissen to a partial Toupet fundoplication, creating less resistance to accommodate that weak motility.
So the preoperative contrast study literally dictates the architecture of the repair.
It does. But the utility of luminal imaging doesn't stop once the patient is closed.
Right, post-op.
Yeah. The anatomical changes made during a hiatal repair, esophagectomy, or a bariatric bypass inherently create new weak points. Fresh anastomoses, suture lines under tension. This is where fluoroscopy pivots from a planning tool to a critical post-operative safety net.
Okay, let's paint the picture. Post-operative day 2. Your patient just had a complex esophagectomy with a gastric pull-up. They are tachycardic, they have vague chest pain, and you suspect an anastomotic leak.
Classic scary scenario.
Yeah. We need to evaluate the integrity of the plumbing before we even think about advancing their diet. But there is a massive clinical catch-22 here that I feel like everyone struggles with. We know we absolutely cannot use barium if we suspect a leak.
Right, because barium sulfate is an inert heavy metal suspension. If it breaches the anastomosis and spills into the mediastinum, it triggers a severe granulomatous inflammatory reaction.
It leads to catastrophic fibrosing mediastinitis. I mean, it's biologically disastrous and incredibly difficult to clean out surgically.
It's a nightmare. So the absolute rule is to use water-soluble contrast, like gastrographin, in the early post-op period. If gastrographin leaks, it's easily absorbed by the surrounding tissues and excreted by the kidneys with minimal inflammatory consequence.
But here's the catch-22. Gastrographin is thin, it moves quickly, and it lacks the high-density coating properties of barium.
Right, it doesn't coat the walls.
So while it's safe for the mediastinum, it's notoriously bad at detecting tiny, subtle microleaks. The contrast just washes right past a pinpoint defect without actually tracking into it.
Which leaves you with a false negative.
Exactly. So if the water-soluble contrast is safer but less sensitive, how do the guidelines actually suggest we navigate this risk profile when a patient is symptomatic?
It requires a highly disciplined, stepped fluoroscopy protocol. You never start with barium. You begin the study with the water-soluble gastrographin. The primary goal of this first step is just to rule out a gross catastrophic leak or massive aspiration.
You're looking for a major structural failure.
Precisely. If the water-soluble contrast flows smoothly, empties into the stomach or the jejunum, and shows no evidence of a large extravasation into the chest cavity, you have cleared the most immediate danger.
Okay, so then what?
Only then, once the gross structural integrity is confirmed, do you carefully transition to a small volume of thin barium. The barium provides that superior mucosal coating to hunt down the subtle, millimeter-sized microleaks that the gastrographin missed.
Oh, that makes perfect sense. It's a calculated escalation of diagnostic sensitivity, perfectly balanced against the physiological risk.
Exactly. It is the ultimate diagnostic peace of mind.
And it protects the patient from mediastinitis, and frankly, it protects the integrity of your surgical repair before you introduce the physical stress of solid food or attempt riskier interventions like passing an endoscope.
It provides immediate, non-invasive confirmation of your operative architecture.
Which perfectly brings us back to the core mission of this deep dive. The esophagram is not some antiquated historical footnote that has been entirely replaced by the high-definition endoscope.
Far from it.
It is a highly dynamic biomechanical roadmap. When you're dealing with unexplained dysphagia, especially when the endoscope artificially alters the anatomy or carries a high risk of perforation, you need the live traffic camera.
Exactly.
You need it to objectively quantify emptying in motility disorders like achalasia, to map out the peristaltic reserve before committing to a complex fundoplication, and to act as the definitive stepped safety net for safeguarding fresh anastomosis in that critical post-op period.
You know, it leaves us with something really important to mull over. With endoscopic interventions like POEM becoming increasingly advanced and high-resolution manometry providing massive arrays of intricate physiological data, we have to ask a big question.
What's that?
Will the ability to dynamically visualize the living, moving esophagus with timed barium swallows become more important, not less, as our surgical techniques become more targeted?
Wow, that's a great thought to end on. As a final reminder, this deep dive is for reference only. Please always ensure you follow your local guidelines in your clinical practice.
Yes, absolutely.
And if you found this clinical breakdown valuable, please don't forget to share it with at least one of your colleagues or friends to help spread the word.
It really helps us out.
Also, be sure to check out our YouTube and other social media pages for more content. And definitely check out our previous season and deep dives. We've covered some very relevant surgical and medical topics you really won't want to miss.
Some great stuff in the backlog.
Definitely. So next time you are staring at a normal endoscopy report, but your patient still can't swallow, remember, You don't just need a sharper photograph of the road. You need to watch the traffic. Thanks for diving deep with us.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.